Okay, good afternoon, everyone. This is Debbie Melnyk with VCSQI, along with my colleagues Ivan Berkel, Sherry White, Eddie Fonner, and Jana Eller. This is our 5th milestone class along the TCPI project pathway, and today we're going to focus on milestone 22, which is 27 for primary care, streamlining clinical and office work. So as you may have memorized, as we do, there are 22 milestones for specialty practices and 27 for primary care. Scores on each milestone determine phase completion. And one milestone may show up in a few different phases because the score changes to complete the phase for the milestone. So again, there are 8 classes that we have put forward for all of you. We are on class 5. Recordings for all of the previous classes are available. Jana includes them in the newsletter that comes out every Monday now, and they are also posted on vcsqi.org website. So today, number 5, and the objectives for today are to review the scoring for streamlining clinical and office work milestones, 22 or 27 for primary care, they are identical. To outline strategies for meeting each of these milestones, to review the relevance of milestone scores to phases, and then to allow for discussion. So at this point, I'm going to turn the program over to my colleague, Ivan Berkel. Ivan?
All right, thank you, Debbie. So milestone 22 or milestone 27 again for primary care asks the extent to which a practice has a formal approach to understanding its work processes and increasing the value of all processing steps. The essence of what this milestone is getting at is, has the practice or has the clinician looked at their key or core processes, talk through them with the team, and identified ways to make small improvements that add value to the customer. And we'll talk more in this presentation about what we mean by customer and what we mean by value. As you look at the milestone, the language in it, and start to think through it, a score of a 0 would indicate that the practice has not started working on systematically streamlining its processes yet. A score of a 1 would indicate that the practice has identified processes that it intends to study and streamline, but the improvement work has not begun yet. A score of a 2 would indicate that practice has worked to streamline a number of its workflows by reviewing the steps and eliminating waste and rework, but the concept of value is not consistently considered during these efforts. And a score of a 3 would indicate that the practice uses an organized approach such as lean or process mapping to review its processes, eliminating or reducing waste in the process, and understanding the value of each process step to the patient and other customers. When many practices do the baseline assessment, it's common for many of them to score a 1 or a 2, just indicating that they are either aware of processes that they want to look at, or perhaps if you've scored yourself a 2, you've started to look at some processes. Maybe you've looked at them by yourself or started to talk through them with the team, but you haven't yet delved into this topic of value, pulled out the discrete parts of those processes that we know add value for the patients or the customers, and have really worked to instill that idea of the value in the team that works on the process. Practices that score themselves at a 3 are practices that have, over the last few months, they can actively describe a process they've gone through to peel apart their practice, whether it's in the clinic or in the hospital, into discrete steps, talk through those steps, and work with the team to talk through how to make small improvements, whether that improvement means to make the process go faster if we're talking about throughput, or achieve a specific clinical outcome if we're talking about a care process. So no matter how you've scored yourself to start, the TCPI project, how you scored yourself during the baseline assessment, what we hope to accomplish over the next few minutes is to talk through this milestone a bit more and share with you some examples of what practices could do or should do in order to score a 3 for this milestone. As always, when we present the milestones, we will refer to the change drivers or the change package that is included in the practice plan. As you see in column H on all of the practice plans, there are numeric change drivers or change package interventions that are listed that link directly to the milestone. And the change drivers for milestone 22, or again, milestone 27 for primary care, are included in section 3.4.1 at the top of this slide. This milestone also includes additional, more detailed interventions that are listed in change package 3.4.2 and change package 3.4.3. We will talk about those briefly at the end of this presentation. The 5 interventions that are outlined in change package 3.4.1 include training staff in lean approaches and the concept of value. Second is considering hiring or training internal experts in process improvement. Number 3 is to use lean principles across the organization, such as identifying waste and identifying value through the patient's eyes. Step 4 is to use process mapping to identify, to document workflows and identify value-added and non-value steps. And step 5 is to convene regularly to discuss and improve workflows to optimize use of the EHR. Again, with these interventions, it's not asking that the practice do all of these, but with a list like this with 5 items, we're looking for evidence that the practice is doing 2 or 3 of these items and is demonstrating improvement as it does so. So let's talk about these in a bit more detail. The first one, again, is training staff in lean approaches and the concept of value. This typically happens when we send staff outside of the clinic or outside of the care team to training. That can take place in the hospital. That can take place through different community resources. That can also take place from just from reading books and articles and journals, et cetera, that have to deal with how this concept of lean was implemented in a healthcare setting and what the results were. Typically, those trainings also orient the participant to a number of tools or approaches that they can take back to their practice or their hospital or their care team and use, and generally be able to duplicate some of the same results that they heard about or read about in their training. That's one way to start to make movement in this milestone as a practice or as a care team. 2, consider hiring or training internal experts in process improvement. Again, if we're not able to send staff through training, it's worthwhile to identify somebody in the practice who has a mindset oriented around process improvement, somebody that's well respected by the staff, somebody that understands generally how the process works from start to finish, and perhaps put that person in charge of learning tools that can be shared with the team and delivered to the patient as a result. The third point, use lean principles across the organization, such as defining waste and identifying value through the patient's eyes. I'll talk about that in a bit more detail in the slides to come. The fourth one, use process mapping to document workflows and identify value-added and non-value steps. This is the essence of where we'll spend most of our time during this presentation. And I'll share with you some examples of different types of workflows or process flows that can be used in the clinic to break down core processes, key processes, into different steps that we can look at and mine improvement opportunities. And last, convene regularly to discuss and improve workflows to optimize the use of the EHR. So not only when we look at process mapping do we break our different activities and steps down, break our different activities and processes down into individual steps, it's important to reflect back on how these steps are done in the EMR, or how different changes in these steps might require different changes to how we document and capture information in the EHR. So tying all these things together and generating small improvements are how practices will achieve a score of a 3 and demonstrate their ability to evaluate processes within their clinic or within their care teams. Are there any questions before I move forward? All right, thank you. The interventions talked about breaking down our key processes into steps, or evaluating our core processes again in the clinic or with our care team. So I think an important question to ask is, what are core processes, or how do we define them? So it's important when we're talking about our core processes to define the scope of each specific process we're talking about. And by the scope, I mean, where does the process start and where does the process stop? When we look at typical patient throughput in the clinic, the process we're talking about is patient scheduled appointment as the start point and patient checked out as the end point. But that process does not account for all of the encounters in the practice. There are some patients we see who schedule same-day appointments, or they're added on the same day. For that process, we would look at the same-day appointment request or patient added to the schedule as the start point, and the patient discharged or the patient checked out as the stop point. If we're an ER, a primary care physician, we have to think about other processes as well. For example, what's our operational and communication process perhaps with patients from the time that they are admitted in the ED till the time they're scheduled in the practice? That is an entirely different practice, different process that a clinician and her team may talk through and develop plans around. The fourth one on this page, what if, for example, you're an inpatient provider, and I misspelled patient on this one, but perhaps you don't see patients in the clinic and you're thinking, well, how does this apply to me? Well, perhaps there's a start point where you see that patient for the first time, and maybe the end point is when that patient is discharged from your service. Let's say you're infectious disease or a hospitalist. The first time you see the patient, that's your start point. And the last time you see the patient, when the discharge orders are written and the patient is sent home, that may be the end point for that process that you're trying to look at. But these are just examples of how we define certain processes as they take place in the clinic setting and in the hospital setting. But there are other processes we can think about as well. For example, our billing processes, our documentation processes, our onboarding processes when you bring in a new physician.
How long will this take you?
Staff member. So these are examples of different processes that we look at or that we can map out as we think through this milestone. There are many more that just need to be defined by the practice as you work on each one. So after you've defined the processes you're going to talk about and map out and try to hopefully improve, the first thing we do is map out the process. How we do that, when we define the process we're going to talk about, this example on the slide is just an ancillary scheduling example with lab and pharmacy appointments. But it's a good example just because it shows how one process can be broken down into multiple steps. So this process is broken down into 22 steps. I'm not going to go through it in order, but I want you to see the way they have the steps outlined in squares with specific activities. Each square is pointing to the next activity, and it's bound by a start point, which is a circle, the patient arrives, and an end point, the patient leaves. There are only 2 decision points in the process, and so everything else is a step in which that indicates the order in which the process must flow to be in order to be completed successfully. For many practices, talking through the process, it's very easy. Let's say, for example, you have a clinician, their nurse, the MA, the front desk staff talking about a process. It's easy in a small practice for everyone to assume, well, we don't need to map this out because everybody knows how it's done. In my experience, I've learned that once we start to map out a process, even just defining what are the endpoints, the stop and the start point, the start and stop point, you will have a lot of discussion, interaction, and debate amongst the team about the order in which things go in. Usually the people at the front desk and the front end of the practice have a certain idea about the way things want and may put the order of the steps in a certain way. The people in the back of the practice, the MAs, the nurse, the clinicians, may have another idea of how things are supposed to work or how things actually work in their world. But when we start to put things down on paper, have a different idea of what the actual flow is, or what the actual flow should be. So one of the things that doing process maps as a team helps to do, it helps to get all of the stakeholders, the team members, on the same page with respect to how a process should work. And a lot of the issues or questions they have with respect to that process will come out or be aired as they are talking about that. Does that make sense so far? Any questions about this? Okay, good. Just to take the process mapping a step further, in order to make it make more sense and be more applicable to the staff at hand, this is an example of a process map that uses swim lanes. As you can see, there are three lanes from left to right that go across the page. And when you're doing swim lanes and you want to break down the tasks or the steps in the process by the individual staff members who do them, that is where you would use swim lanes. So in this example of a PA office visit, an office visit with a physician's assistant, what we attempt to do in this map is to break the swim lanes down into different individuals, not just staff, as I said before. The first line represents the patient, and the two bars below, the thicker bars with the majority of the tasks in them, indicate the PA and the PA assistant. And so as we look at the process, it's got a start point and a stop point indicated by the ovals at the top. But then the different steps in the process are broken down according to who does them or who should do them. This type of a view is particularly helpful when looking at a process that we know touches 2, 3, or 4 or more people in a practice. This way we can see, and it's clear for everyone to see who does what, the order in which things are done. This way it helps teammates plan for how we can help each other. It makes it clear to others in the practice perhaps how we should document or how we should plan for what the patient may do next. It also may indicate who's doing the bulk of work in the practice and may point toward opportunities for how we can shift work or share work between different staff members, especially when one or more staff members becomes overburdened or seems overburdened by the workload. So once we identify our core processes again, identify the different steps that are involved in the process, one, creating a process map is good just to understand the flow in which things happen and perhaps the time at which it takes to do them. But when we go a step further and break things down into swim lanes, then we can understand who does what. And again, it not only helps us understand the process, but helps us understand how we can make the most of the team that we have that's doing the work in the practice or within the care team for our patients and for the practice overall. Now, what happens if you're in a practice or you're in a clinical environment, a care team, where you don't have the the software, the technology, the different programs that you would need to create process maps. What I found to be very helpful in practices that I've managed and teams that I've worked with in the past are to use Post-it notes on the wall of the practice in order to do this with the team. Post-it notes can sometimes be more effective than doing a process map in Microsoft Visio or PowerPoint or one of those other programs and sharing it with the team, because when you use Post-it notes, the team becomes involved in developing the process, and it's a very manual process that engages them right from the start. And the way you would do this with a team, take that core process, for example, of patient schedules an appointment, the patient is discharged from the practice. The way you would go about doing that with a team is you would start by creating Post-it notes and writing those two boundaries and putting them on two ends of a wall, let's say. And in my experience, doing this with the team in the break room over lunch is ideal. Everyone's going to sit for at least 30 to 45 minutes. There's typically a wall close by. They're sitting down, they're thinking, they're paying attention, they're concentrating. And that's a forum I find works best for doing these types of process mapping events. But once you get the bounds set up, so for example, let's say we were using this colorful example at the bottom as an example. And let's say you wanted to pick a start point and an end point. Once you have those up on the wall, you ask the team, even though you may know yourself, what are the 8 to 10 different steps that take place in the practice between the start point and the end point? And once they come up with those and you have a shell of what the core process is, then you can add more details in between. You can add decision points, things like that. You can also use different colors to indicate who does what. So for example, you can use different colors or different, you can turn the Post-it notes to make different shapes, diamonds versus squares, for example, in order to indicate different work being done by different members of the team. That way, when you're done, we have not only a visual of the process and the flow, but if we don't have swim lanes, we can at least go back and say, okay, for this one, for example, a lot of the work is done by the staff member represented in orange. A lot of work is done by the staff members represented in pink and red, these colors, but not a lot of work is done by the staff members represented in blue. So it becomes a conversation of how do we share the work, or at least how do we make sure that the right tasks are being done by the right person. So again, process mapping with Post-it notes is another way that practices can use to engage the team in developing easy to use, easy to understand process flows or process maps without having the technology or the software to create them on our personal computers. And once we develop the maps, and this is especially true of the Post-it notes, the maps we use with Post-it notes, once we do that and we put them up in the staff room, the break room, things like that, it's easy for staff to come back to, look at it, mull it over, especially on those tough days when things don't go 100% according to plan in the practice. I find you'll often come back in the break room and see staff standing by the workflow map, and they will look at it and they'll start to think or ask questions. Well, maybe if we move this over here, it would work easier. Or if this person did this job, it would be easier for the practice. Or maybe we tried this today, but it took too long. Is there another way we could do it earlier in the practice so it doesn't create this wait for the patient later on in the practice? So that's just some different ways that, that once we create the process map, if we leave it in a space that's visible for staff, it will continue to engage them in the practice's overall processes, but it will also engage them in day-to-day problem solving within the practice as well. And process mapping is a very important part of what Milestone 22 and 27 are asking us to do in the practice, again, just to evaluate how are we doing as a practice and how could we be doing better. The interventions I spoke to, 3.4.1 again, 2 or 3 of them mentioned the word lean philosophy and lean principles, and I'm going to take a few minutes to explain those in more details. Many individuals now in healthcare have heard the term lean, and the word lean as it's used in this process improvement setting really does not have a lot to do with staffing down or whittling down resources to become quote unquote lean as a practice. The word lean is essentially a business management and problem solving philosophy that came out of Toyota manufacturing processes way back in the 70s that are really, that have to do with making small improvements, small changes based on continuous improvement and empowering staff to problem solve in real time. So it's not about becoming lean, it's about creating a set of tools that will empower staff to problem solve, and creating a process map is one of those tools that helps to accomplish that. Some of the key underlying principles for lean are the customer, in our case, the patient, always comes first, and the patient decides what is value added and what is non-value added. It's easy to talk about the patient in healthcare, although it's quite true that we have many customers whom we have to focus on. The patient is a customer, of course, because they are a recipient of a lot of the care that we provide. Sometimes the payer is the customer as well, and we have to think about what the payer wants and what we need to do in order to get our bills submitted and paid correctly. Sometimes our staff, the physician, can be customers as well if the specific process we are looking at is tailored specifically to them. But in general, when we're talking about healthcare and talking about the practice or talking about the recipient of the clinical care that we are giving, the patient comes first, and the patient is where we determine what is value added and what is not. The second principle I've touched on a few times, but it forces us to identify what is value added and what is not once we have defined the process. That now is not to say that if a step is not value added, that we should skip it. That just forces us to think, okay, if this is a step that must be done in order to complete the process or to comply with the process, but if it is not value added, how do we make it easy? How do we make it quick? How do we mistake-proof that part of the process so that it doesn't disrupt care or affect the patient in any way, shape, or form? That's what the challenge of going through the steps and determining whether it's value-added or not value-added. That's the benefit of that process in the overall continuum of patient care. And the third principle I will speak to is that lean challenges us to continuously improve processes by eliminating waste. And in order to eliminate waste, that's where it becomes important to get staff training on lean principles, understand the key types of waste, and be vigilant, be on the lookout to identify those and eliminate those where possible in the practice or within the continuum of patient care within the hospital setting. So the 8 types of waste in lean, we use the acronym downtime to summarize them. I'll go over them briefly and try to give you an example of each. The first type of waste is a defect. And a defect is essentially doing something the wrong way or producing an error. In the clinic setting, a great example of a defect is a bad registration. It just means we got the wrong information. Perhaps it might not be the practice's fault, it might not be the patient's fault, but it is a defect in the sense that we got the wrong information, which means a full registration could not be completed, which means when the patient comes in, they will have to do it again, which will take more work, more time, et cetera, et cetera. Overproduction, that's a common type of waste in the practice as well. That's when we are duplicating efforts or producing more of something than we need to provide the immediate care for that patient. A lot of times in the clinical setting, we duplicate tests. We order things that have been done before. We do this in order to have immediate access to the information. But lots of times if we dig around a bit more, we will realize that what we were looking for is already there and wasn't necessary to do to the patient, and wasn't necessary to produce another bill or a cost perhaps for something that had been done already. That's an example of overproduction. Waiting. From the patient's perspective, this can be waiting to get an appointment. That's how we work on things like access. It can be waiting to get called back. That's why we work on things like throughput time. For the physician, if the physician perhaps is the customer in this case, it could be waiting for the patient to get ready, waiting for the MA to be done with his job or her job so that the physician can get back in the room and see the patient and maximize the time the patient is there. Waiting in any way, sense or form is a kind of waste that we should look to eliminate or reduce as much as possible. The N in downtime stands for not using talent. This occurs when we are not using our staff to the best of our ability or using our staff to the top of their license. And so anytime that we're having our staff members do a skill where the work would be better delegated to someone whose skills are matched to that work, that's an example of waste, and we should make sure that we are matching the right people to the right jobs that must be done. If you recall from a few webinars ago, we talked through Milestone 6, which had to do with identifying the right roles for each job and making sure that we are pairing people to the right work. This type of waste addresses that same thing. The fifth waste, transportation. This can be from excessive transportation of things, materials, paper, or people to different places in the process when they might be able to stay in the same place and have things come to them. This is an issue, can be an issue sometimes for older patients in the hospital setting or in the clinic, but we as operators should look for excess transportation within our practices, within our care teams, and work within our teams to eliminate excessive transportation of people, products, or things that we are using in the care of the patient. The sixth item and the sixth example of waste is inventory excess. We know that other than our staff and labor, that supplies and inventory are typically the biggest costs in healthcare, and lots of times we tend to have more supplies, more equipment, more inventory than we actually need at the time to deliver care. So having a good supply management program, making sure we have our hands on how we're managing our equipment and the costs associated with those, making sure we're not using or purchasing any more than we should, while making sure that we don't run out in the practice. That's an example of waste that we can monitor and manage in the practice. Motion, that's excessive going back and forth by one person to do different tasks in the clinic or within the practice. For example, an example I like to give is, let's say you're in a small practice and you're in a space that has multiple rooms, maybe 4 or 5 rooms. Sometimes the team feels that if they have more rooms available, they can get more patients in, they can flip more quickly, they can get more done throughout the course of a day. But what that causes sometimes is that more staff have more rooms they have to go in and flip between different rooms. That can take up more time. That can cause waiting waste, that can cause excessive transportation waste, that can cause a number of the waste that we've talked about already. So where possible, try to restrict the motion of people to as small a space as possible. There have been examples in the past where different spaghetti diagrams have been made to show, for example, where and how much a nurse can walk during the course of a day or a shift. Oftentimes, when we take a look at those spaghetti maps, we see that clinicians can sometimes walk miles during the course of a day, just going from room to room, office to office, space to space. So working to minimize the motion for staff, that's one, a staff pleaser, but it's also a good indicator that the practice is looking at and finding good ways to eliminate waste for staff members especially. And last, excess processing. This means doing things, perhaps the same thing more often or repeatedly that we don't have to do. Perhaps there's an alternative way that it could be done. Perhaps it's been processed already and is someplace where the information just cannot be found. But anytime we are duplicating things or creating rework for staff, even if we do something on the front end, a check-in that needs to get duplicated in the back because the information wasn't shared or wasn't documented correctly in the EHR, those are things that can sometimes come out in discussion and the teams can work to remedy over time. Especially again, if you're process mapping, if you're bringing out the different steps involved in each process and you're talking about it as a team, that's where a lot of these things will come up. I mentioned earlier that I would talk through briefly what's in a change package or TCPI driver 3.4.2 and 3.4.3. I'm not going to read through all of the items on the slide right now, but the items in 3.4.2 really speak to supply, inventory management, and using staff to the best of our ability. So the top, the first few interventions speak to making sure that we have an approach to inventory management, making sure we have a standard way for how we set up rooms and store supplies in rooms. In some clinics, for example, where you have different types of clinicians or providers, you may need to sit down with them and reach consensus for what needs to be in a room and make sure that they're there specific to the needs of each provider, so that once they get in the room, they don't have to leave the room, or they have to leave the room as little as possible to get supplies, bring them back, care for the patient, et cetera, et cetera. And some of the items at the bottom of the slide speak to our ability to cross-train staff and standardize their work across different teams or different sites. And this becomes very important when you have a small number of staff that are working between multiple providers, or perhaps your clinic has a number of sites and we ask staff to go from site to site. And if we have standardized processes across those sites or standardized process teams from physician to physician, that's going to reduce the variation across the practice, create more consistency for both the team and the patient, and that will deliver a better and more consistent patient experience. What's in change package 3.4.3? These have to do with maximizing provider value, especially when you're in the room with the patient. So some of the interventions we speak to minimizing the interruptions or the possible interruptions to the physician. Making sure that we have standardized processes in place for how we schedule, how we add on cases, how we use the physician's time, how we document, standard processes for how we're going to use rooms and how we're going to flip between rooms, and how the physician and the team are going to work together to make sure that we are getting the most or the optimal number of people in those rooms, in and out of those rooms each day, and using our staff to the best of their ability to make that happen. And so as you have a chance, read through these items in more detail. Again, when we talk through the interventions that are given for milestone 22 and 27, we know there are a lot of them. Again, we're not saying to practices that you need to do all of these, but as you look through them, there are some of them which you may have in place already. Excellent. That's a good start. I think what we are asking you for practices to do is to evaluate what else can we put in place, which of these items are we not doing that we should be doing, and how can we start to engage our team to make sure that we are evaluating our core processes, breaking them down into steps, looking at them as a team, and determining how are we going to make small improvements to provide better care for our patients day in and day out. With that, are there any immediate questions or comments from the members of my team that come to mind?
Thank you, Ivan. I'm reminded how helpful process mapping can be to really understand not only the work that needs to get done, but who does what, and where, you know, duplication that's not intended is occurring. So eliminating it from one person's role makes it, you know, a more efficient process. And then where duplication is intended as a double check for safety or quality reasons. So thank you. I think all of these tools are advantageous, not only for becoming a more efficient operation to getting better results.
Agreed.
So next week, our topic is coordinated care and population management. And you'll see there are several milestones we're going to cover. There are some similarities, of course, between specialty and primary care. Again, Tuesday at 7 a.m. and 5 p.m. Eastern Time, and Friday at 10 a.m. Eastern Time. Thank you again, all.